Good afternoon, everyone, and welcome to this online event looking at digital technologies and interoperability, enabling the future of integrated care. My name is Dr. Lorraine Chikwera. I'm a research assistant at the King's Fund, and I'd like to start this session by thanking TPP, who've sponsored and funded the event, and I'm looking forward to the discussions. We have a great panel of speakers today, representing a whole range of perspectives, and we'll meet them in a moment. We also have a great audience for this event, and we have about, I think, 1,000 people who have signed up, which is quite exciting. And there's a real range of people watching from across different sectors. So we have NHS commissioners, people from charities, patient representatives, and people from universities. So this event is live and includes a panel discussion and a live Q&A. And would like to invite you, the audience, to submit your questions. And you should be able to see a Slido box to the right of the video, which is where you can submit your questions and upvote questions others have asked. And we will aim to answer the most popular questions. We'll also be putting up a poll, questions to the audience. These will flash up at various points across the session to the right side of the video. So please do take part. And we also encourage you to follow the conversation on Twitter using hashtag KFOnline. And again, recommend that you look at the resources page. On the left-hand side is a menu with a series of options. You can navigate to the resources page here. And I'm delighted, again, to let you know that we have launched the report. And our discussion today is going to be part of that. And our report, Interoperability is More Than Tech, the Role of Culture and Leadership in Joined-Up Services. So we'll be discussing some of the points raised in our report today as part of the discussion. And if you want to have a read of our report, and I'd encourage you to do so, please find a link to the report in the resources section of the platform. So before we start, we'll just go to the panel so they can briefly introduce themselves and their roles and experience of this topic. So I'll just start with Savi. Can you please introduce yourself?
Hello, everyone. Welcome. Thanks for your time for being here. My name is Savi Cartwright. I am Strategic Clinical IM&T Consultant for Cambridgeshire and Peterborough ICS ICB. My involvement in interoperability is I have got 2 decades of experience where our work across the settings, and hopefully I'll be able to answer some of your questions. Thank you.
Thank you, Savi. I'll go to Julia. If you can introduce yourself, please.
Good morning, everybody. My name is Julia Millman. I'm an experienced programme manager. I began to work with the health and social care environment in 2014, initially leading on the development and implementation of the Leeds Care Record, and then moving on to the development and implementation of shared care records for the Yorkshire and Humber Care Record. And I'm happy to join in and have this discussion with you all today.
Thank you, Julia. And Matt, please.
Good afternoon, everybody. Thanks for joining us. My name is Dr. Matt Curtis. I'm a GP. I've worked as a GP for about 20 years. And for 18 of those years, I've been lucky enough to work in West Yorkshire, where we have a high degree of interoperability. TPP are proud to sponsor and support the work of the King's Fund. And we're passionate about interoperability. And I'm looking forward to sharing some of our experience with you.
Thank you very much. Next, Ian, please.
Good afternoon, everyone. I'm Ian Townend. I'm the Chief Architect for Transformation Directorate within NHS England. So I have a responsibility across architecture and pieces of standards and interoperability. I've worked in the NHS for 17 years now. And I started out doing HL7v3 messages, which are now a thing of the past, but still a lot of those flying around as well.
Thank you. And lastly, Sam.
Good afternoon, everyone. And Lorraine and King's Fund, thanks for inviting me. I'm Sam Shah. I'm an honorary consultant at Royal Wolverhampton NHS Trust and Chief Medical Officer for Newman. Previously involved in digitisation for NHS England, and have had lots of experiences both from inside the NHS and outside of the topic and discussion of interoperability and integration of services? Thank you.
Well, thank you all panelists. Looking forward to what the discussion today. So before we start, I think it's important to just give a summary of the project and then later on parameters for this definition of interoperability. So for our project, we sought out to explore people's understanding and experience of interoperability, and also looking at the barriers and enablers to good interoperability or effective interoperability. And we used different methods. So we had focus groups with different people. We also had individual interviews, one-to-one interviews, and 2 case studies. And some of the people that are involved in the case studies are here today to talk about the experiences. The participants we had were from across different sectors. They were also in different roles and had different technical expertise. And I think it's also important to set the parameters for a definition of interoperability. We recognize that it is quite a complex concept. So for us, it's really thinking about that interoperability encompasses different elements that are interrelated. So as you can see from the slide, that there are different aspects to it. So what we're focusing on and using as a working definition today is interoperability is not just about technology. It's about how people and systems talk and work together across organizational structures and professions, and technology supports this work. We also recognize, and it's important that we realize that it's an ongoing process. So there's never an end to it. It's constantly shifting and changing, and it's quite a dynamic process. So I think it's very important for us to have that definition that will help us think about some of our discussions. And I guess for the audience is also thinking about some of your experiences and questions you might have for us later. So to go to the panels, so first question for the panelists this afternoon. So the first question is, what has been your experience of using technology, including data, to help join up organizations and services? And what challenges did you encounter? So I'll start with Ian, if you can just start us off, please.
Sure. So I've worked for quite a while across various kind of programs within NHS England. So I guess probably the biggest one in kind of some of these joining up the areas in technology organisation services was probably around local health and care records. So shared care record program that exists now that I know Julie is part of for Yorkshire and the Humber. I'm also in Yorkshire and the Humber, so there's definitely three of us up in Yorkshire today. And that was a key area for us in terms of actually building the architecture, supporting some of that funding, designing the standards and the interoperability solutions around that. There's still a fairly long way to go in that. Not all the countries yet covered by shared care record. We still need to deal with sharing in between those care records. But one of the key things I think for us nationally in terms of areas of focus is, as we're moving forward, the Secretary of State recently set out her new priorities around ambulance emergency care as we move into winter in particular. Generally access to care services, how are we improving that kind of access, and a big piece around workforce. So there's an area for us to do with one of our key priorities at the moment, which is a program called Who Does What, setting out what we expect to offer nationally from the centre, what we expect to be at an ICS level, and what we expect to happen at a local level. So we're working with a series of partner organisations across ICSs and local trusts around that at the moment. And I think some of the key standards that we're coming into there, we're going to talk a little bit about later. So I'll hold off there, and I think hand off to Sam for some perspective.
Well, I think, from my experience, I want to give you three views on this. There's the perspective of joining up services and a national set of priorities. And Ian touched on one of them, which was urgent emergency care. And for a long time, when I was in Ian's organisation, I was very involved in trying to connect these services together and the sharing of information and data between them. But then, of course, on the front line in clinical practice, of course, have the challenge of working in a service and a set of services that don't necessarily have access to the data. So it's great when there's a national priority, but actually the reality is in my clinical practice on a Sunday, I will have zero access to a patient record, which is, of course, something that the NHS claims to be doing and has apparently done. And then there's the reality of the complexity and mixture of services we now have. Patients, citizens no longer just access just their GP service or just their local hospital, but they use a mixture of services for different things. Their local pharmacy, their dental practice, their optometrist, a lot of other services that don't necessarily have access to the record or able to write to a record, read from record, all of these things. So in my experience, there's a number of challenges. The priorities are not necessarily always aligned with the reality on the ground. The organizational design that the NHS is working from is often one that is stuck in a set of services from perhaps 1977. And then there's the funding model. There's the national expectation of what the funding actually is. And then there's the reality on the ground as to how it can be delivered and whether the technology can be delivered within the envelope available. And then there's the resourcing, of course. And I have every sympathy for suppliers, because I see a situation where suppliers are torn in every direction between local organizations, national priorities, and the glue in the middle. And then at the same time, there's an expectation from the NHS of delivering against this when it can be very confusing. So I think the ambition is great, but at the same time, I think the reality on the ground is incredibly difficult. And it's the same discussion we've been having for at least the last 10 years.
And so building on that, I think I'd like to share with you a little bit more of my experiences working with local organisations. I think really my insights are around the adoption process, and that starts with the engagement part of the process, because organisations, we need to be really honest and clear and transparent up front with those guys. They need to be technically ready for interoperability, and that means we need to be having a few questions up front. Are they working with suppliers, or are they growing their own EPR, for example? Can they support the basic principles of interoperability? So, for example, Internet First being one that's a principle of the Yorkshire and Humber Care record. Did they have up-to-date infrastructures? And then looking at their data quality and data maturity, because you can't really share information that's not good quality information either. And then looking at their operational readiness, they need to be relatively agile but stable enough to manage change. And that means they do need to have at least some formal decision making, executive buy-in, and the flexibility to deal with crisis. As we all know, COVID came along and took the legs off most programs over the last 2 or 3 years. And we need a little bit of space and capacity for crisis management around interoperability as well.
Thank you, Julia, and thank you all for your insights. I guess for Matt, I know Sam talked about suppliers. If you can talk a little bit around what does the supplier struggle with, and how can working with leaders and providers help both sides?
It's a good question, Lorraine, and we never struggle, but we like a challenge. And suppliers, I think, recognise that interoperability has to be everything to everyone. And there lies the challenge in that, as Sam said, the priorities of patients may not necessarily align with the priorities of staff, which may not align with the priorities of the leadership. We recognise the fantastic local innovations that bring about local care records, but we are aware that there's a need for regional and national interoperability as well. And there has to be a national standards whereby all of the interoperabilities play nicely with each other. We, as a supplier, recognise that the way in which contracts are enforced seems to be at times variable. So the way in which primary care IT is mandated and very rigidly controlled needs to be the same in the secondary care sector. There's no sense having a primary care IT system that can receive structured data if there's no secondary systems sending it out. So the enforcement of the rules must be even across the board. All interoperability works best when the relationships between the organisations are strong, and that is easier to do in organisations which are which are similar. So primary care organisations work well with each other. They work slightly less well with secondary care organisations. What we have to do, though, is get better at working with social care organisations and voluntary sector organisations to truly deliver interoperability for all citizens.
Thank you very much for this insight. Sam, would you like to come in and add something?
I would. I think Matt mentioned something really interesting there, and it sort of follows on from the discussion we had earlier. And we can use the example of ambulance handover as a good example of this very problem. You've got ambulance providers that themselves are up against it. Their staff are burnt out. They don't have much resource. Their supplier community, their technical supplier communities have not had the development that some other parts of the system have. So we're suddenly about to put a lot of pressure on ambulance providers and their tech suppliers. And at the same time, we haven't developed that ecosystem. We haven't put the resources in, and we probably won't put the level of resource in required to create the technical build to allow the handover to take place. And we've got to remember, this is an ecosystem. So that very primary care provider community and their suppliers are part of that information flow. So we do need to get an alignment between the expectations, the way in which you manage both the suppliers and their providers they're working with, and the resourcing that all parts of the system will need, which I still think we're far away from.
Okay, thank you, Sam. Savi, would you like to add with something else before we move on?
Of course, yes, I'll keep it very short. Thank you. For me, is I couldn't add any more. I see that as constantly reacting to the problems is coming at us. And this interoperability is all about people and people and people. And that's the center of it. And we're trying to achieve to give the best care for our patients. So that's around the people are elements of to that put into the front end and to the end, and where the patients are getting a care and connecting all that together as a communication and putting in people in the middle. Thank you.
Thank you very much, Savi. And thank you for your points. I know we've talked about systems and now we've talked about people. So I guess my next question then is, what current opportunities have you found there are to progress interoperability? And Ian, would you like to go first?
Yeah, thank you. So I think I was going to touch here on what work we're doing around some of the key standards that exist and how we're raising kind of awareness and how we're supporting people in terms of what to ask for in contracts and things like that. So there's a range of things that are kind of happening at the moment in the centre, and some are on track, some are slightly delayed with a range of changes happening at the moment. So we have a drafted national standards and interoperability strategy, which is mentioned in the report, which is going through kind of a final set of comments now after we've received quite a lot back. Thank you for everyone who's contributed to that. Our kind of next big thing nationally is a standards portal. So we've been developing, one of the things we heard quite a lot was people aren't certain whether that's providers or suppliers on what standards should be implemented where. So we've developed a standards portal, which is now in public beta and is accessible to everyone now. And we would love feedback on that. That's still ongoing. So that aims to set out, here are the standards that are available nationally. Here are the areas in which they should be implemented, to kind of give people that holistic view. And our intent is that we develop that portal to become a little bit more than just kind of a directory, but it'll also allow people to suggest new standards that are missing, provide feedback on standards that are in place as well. So to kind of try to create that as not a national organisation setting those standards without consultation, but bringing the entire community together to make kind of better quality standards in that space. Some of the key kind of services and standards, I think, certainly for me, that are in areas that we're leading on. So GP Connect is one, or direct care APIs. So there is a service nationally. It's available to access GP data. It uses FHIR messaging, and anyone can access that. It doesn't have a cost to it. There's an onboarding process, of course. And some of the big standards, so won't be surprised to hear things like FHIR is our direction of travel for the interchange of information in terms of that technical level of interoperability, and then bringing in some of our coding schemes like SNOMED CT, DM&D, for some of the semantic content in that. So general practice is pretty well covered now in SNOMED CT. All the GP suppliers use it. It's used in practice, even if it's behind the scenes. Secondary care, less so. So that's kind of the focus of our SNOMED piece. It's going to happen over the next couple of years. NHS number, so already very widely used across health. Perhaps a little bit less so in social care. So our focus kind of going forward on the NHS number will be around social care. GS1 and scan for safety. So we've had a lot of questions around this previously. So this touches on clinical practice, but also into some of the administrative, including procurement, finance, logistics. We have worked with some of the demonstrator sites already there, Leeds, Derby, Royal Cornwall, and our intent is to have a bit of a revamp of some of that scan for safety. Barcoding standards doesn't sound like it might be the sexiest area, but it is once you get into it. And then the final two really that are kind of big focus at the moment, standards for pathology. So a unified ordering list, updated messaging that's still uses Edifact. It's quite 30 years old. And then the big one for me at the moment, transfer of care. So how are we getting information back from secondary care into primary care with three focus areas around discharge from acute inpatient stays, mental health admissions, and outpatient letters. They're the three kind of immediate focuses, and we are going to be consulting on what the next set of focuses in that space should be. Big contenders like ambulance handover, maternity discharge, but we will be going out to a consultation to kind of bring in views from across the service on what those should be. So I could carry on talking about the standards and the work we're doing for a long time, but I won't hog all the time. I think.
Yes, thank you, Ian. I'm sure you have loads. Thank you, Ian. Savi, would like to come in?
Yes, of course. Thank you. Opportunity for us is as a Cambridgeshire and Peterborough ICS. We just recently has become an ICS now, so we're going through this new world into ICS. That's an opportunity as in bringing us together from ICB and ICS people and working in such a hello.
Yes, Savi, we can hear you. Please go on. Yeah.
Yes, shared care record. So we are embarking on delivering a shared care record. That is one of the biggest one that is in our pile. And we're looking at as a system together, how do we bring a workforce into the center way and using and capitalizing their skills and upskilling our staff across the systems. In terms of governance, ICS governance, we are giving a stake in terms of maternity, mental health, and social care. And that collaborative working are panels where we started to looking at circular approach. Thank you.
Great. Julia, would you like to come in before we move to the next question, please?
Yeah, sure. I had three observations with respect to this question. So I think the first is plug and play products, which sounds a bit simplistic, but actually from a regional perspective, developing interoperability and then making it really easy for other organisations to follow on from what the early discovery sites have done. So my examples around that would be the ambulance transfer of care, which we've worked extensively on for a year or so now in the Yorkshire and Humber Care Record and have live across 6 ED departments in the Yorkshire and Humber. And then another example would be our booking tool. So these things, if you disseminate them down to quite simple plug and play products and take out the complexity over time by iterating the process of implementation, then working with your partners and extending that across ICSs is possible, we think. And so that's a big focus for us at the moment. The second one would be empowering people, because I am personally, and I think the Yorkshire and Humber Care Record as a programme is very passionate about ensuring that the health and social care workforce are self-sufficient wherever possible. So developing things like access to our Yorkshire and Humber Care Record Academy, and also having accessible libraries where people can easily get information that's clear and transparent for them. And then also white labeling products. So for example, our information governance is all white labeled to make sure that people can just pick it up and use it. So those would be really my main observations.
Thank you all for those examples. So I know we've talked about standards, we've talked about different programs and systems. I guess my next question is, from our report, interoperability and joined up services, for it to progress, we found that good technology is not enough. Relationships and a culture of collaboration need to be developed, strengthened, and continually sustained across organizations and professions. So the question is, how can we ensure partners work as part of cross-organizational teams to achieve interoperability? So I think that's a key one. So starting with you, Sam, if you'd like to come in, please.
Yeah, I mean, this is notoriously difficult. If I think about the many years over which I've sort of had to deal with this with different groups, the first thing really is that shared sense of purpose and value, and the reason that we want to do this. What is it that we're trying to achieve? What's the outcome that we want for our citizens, for our people and our system? And certainly in the current climate, this is something that I can see becoming more difficult. We don't have the capacity necessarily across all our services. So we have to work in different ways. Workforce retention is a problem. So we might be using a different type of skill mix. So that means a different type of thinking. And to give you a very practical example of that, people will start accessing services from other healthcare professionals as part of their shared care across a system. So that means that when we are working together collectively, we need that shared sense of purpose, those values, which then may drive the use case for interoperability. But we've got to move away from interoperability just being a process or a program or a set of projects, but something that relates to the purpose in which we're doing it. And that is ultimately to deliver an outcome, to deliver care and provide access for the population, would certainly be my starting point.
Thank you, Sam. Matt, would you like to come in?
Yeah, I'd echo what Sam said. As a system suppliers of many of them have been in this place for 10, 20 years. They've got great experience and great knowledge about obviously their products and how they interact with others. And what system suppliers can do is really show a vision of what could be achieved, pushing the technology to its limits and then extending those limits. I suppose what we mustn't forget, though, is that it's all about the relations between those organizations. Those organizations are actually probably pretty good at working together if the technology is rubbish. If the technology is good, then wow, think what they could achieve. But it's their relations between each other that are crucial to this.
And Lorraine, just to come back on Matt's point there, we've got to also think beyond how we traditionally have worked. So when we end up with national programs, we end up fixating on secondary care as hospital and primary care as GP. Well, I would keep on saying that actually primary care has three other poor cousins: optometry, pharmacy, and dentistry, and many other healthcare professionals in the network of primary care. So we need to change the mindset as well around who it is that's involved in the care of patients and people. But equally, on the other side, be open to listening to suppliers and providers of how they've solved problems elsewhere. So when NHS England or anyone else comes to the market, don't ask for a particular product-based solution, but to put the problem out there and let people think about solutions that they might find from elsewhere that they bring to the problem rather than a product.
Completely agree, Sam. My experience in recent times is that we faced real challenges, obviously with the pandemic, but with workforce. And by talking to system suppliers, we were able to use the tools that were already there rather than having to reinvent something from scratch.
Absolutely agree with you, Matt. And talking about mindset, Sam, that is absolutely true. It is about the behavior, what we're thinking about. We are often really great in deploying systems. And are we following it up, having the adoption, optimizing the system? What is the missing at that point? For me, it's a people part. Taking through the change for our people. We stop the change saying, here it is, take the system. Are we going back and continuously supporting them, making sure they are sweating the system that we're given? And that's where I can see the return on that benefit. And the whole cycle of that is, for me, is I think critical. Thank you.
I think for me also it's about making sure that you keep the patient or people, as you say, Savi, at the centre of the conversation, making sure that there are mechanisms in place to have an ongoing and authentic conversation over time with citizens, rather than just at one point in time conversation. I think that's really important. And then also having the space to collaborate about innovation, things like technical design authorities, clinical design authorities that are actually held at all sorts of different levels, local, regional, national, to make sure that everybody has a voice and everybody's involved.
Thank you all very much for answering those questions and for your insights. Now we're just going to go to the Q&A. And one of the first questions that has come up for us, and we did talk a little bit about this when we started, around the definition of interoperability. So if I can start off with Matt and then go to Ian, if you'd like to answer that question on what it is it, and what it is not.
It's a great question, and it's asked many, many times, and of course it can mean different things to different people. My passion about interoperability is, as I said before, is based on the good relationships between organisations working closer together for a shared goal. A patient quite understandably expects the NHS as one organisation to be able to use all of the NHS's information with appropriate controls to deliver care to them. And there must be millions of consultations that have happened where patients are confused and surprised. As Sam said on a Sunday, why can't my clinician see the information that everybody else knows about me? So interoperability must be about the patient's needs first. As a clinician, interoperability mustn't be just a stapling together of different records such that the clinician has to bodge their way between different screens to see what's going on. It must be seamless and user-friendly. We have to recognise that clinical and NHS training doesn't give enough attention to IT literacy. I've been taught how to use a stethoscope, but my use of an IT system is something that I've had to pick up as I've gone along. And therefore, the systems that we use, the systems that are interoperable, must be user-friendly. So that's what I think interoperability should be.
So I'll build on those, because I think the report defines kind of the technical aspects and then importantly the semantic aspects as two very distinct things, but then does get into the people and the relationships. I think for me, when we've been looking through some of the work, where does the interoperability piece start? And actually it starts on the input of information into the system. So working with people like PRSB on some of our content standards, actually these are the things that we might expect to be going into a system, and then looking at the technical elements and the content that goes out. So what does a good discharge summary look like, for example? The semantic piece around how do we make sure both understand the information that's in there. One of the things that's really come up for us around the transfer of care is also what do we expect people to do when they receive the data? So around a discharge summary, for example, what are the activities that we think a structured discharge provides for general practice? What are the activities that should be undertaken either by the system or by the people who are receiving with those discharge summaries? And I think the final piece for me, probably around to just touch on the interop, is about how you use / present that data. And it was a really good example of when we went to Leeds probably 4 or 5 years ago now, where they talked about overload. And actually, you know, when you pull a GP record back, for example, it's got your entire history of medications in it. Is it really relevant there and then that when I was 8, I had an inhaler for asthmatic hay fever? Probably not. What's really relevant is when the active medication. So actually, what are the things that we do at one end to filter so that we don't end up with clinicians having 1,000 data points to have to go through when actually they only need to look at maybe 10 or 15. So I think that's that entire end-to-end interoperability process.
If I could just come in there and maybe just build on what Matt and Ian have said with an observation. From my experience, thinking about people on this point is in terms of the user experience is quite interesting, because we've all got mobile phones, but the thing about mobile phones is they can be customized within an inch of their life to whatever that individual user would like to do with that phone, whereas a shared care record cannot be individualized to that level. So the information which a GP would need in a consultation with somebody potentially dealing with a bout of the flu is very different to the consultation of a cancer nurse that's speaking to someone about the end of their life. So that fine balance, one of the challenges that we have with technology when not balanced with people and process, is that fine balance about what all the different types of user want, and helping them to understand that they might not actually be able to get specifically what they want as an individual. They have to work as a team to get the best fit for everybody when it comes to data sharing. I'm interested to see what Matt's thoughts and Ian's thoughts on that are as well, I suppose. Again, back to you guys.
Yeah, I think that's a really key point, because I think, you know, the needs of that cancer nurse at an end of life are completely different to the needs of a GP or an A&E consultant at the time. And actually, how do we use some of the data and the people elements to customize those views? Because I think that is the thing I was saying, that rather than having all those data items, it's a much smaller, but actually it's a much smaller presentation for, like you say, that cancer nurse needs something very, very different to other clinicians.
Sure.
Yeah, I completely agree that the great success of IT in the healthcare setting is that there is now enormous amounts of data points, as Ian said. And I, in recent times, have begun to realize that I'm often looking for a needle in a haystack. So that national care record that is that's tailored for my unique needs, wow, that's a holy grail. But I think we're moving in the right direction.
If I can build on that, Matt, I mean, data is a king. It is about the power of data, and we got to think about the quality of the data and data management, the integrity of the whole data. And this is going back into the interface, certain limitations, data that needed for a certain professional, so that they can do their job in right time, in right patients, all the time. And that is the simple should be.
Yes, can we have Sam come in on this last point?
Yeah,
and we can move on to the next question.
I think I have to be careful not to get into the design of our user interfaces and the use cases here, because fundamentally the interoperability and the question around it is about the exchange of data, often in 2 or 3 directions, and making use of that in some form, and turning that from data to information to intelligence, perhaps. But all the other things around the user experience, the design, well, they can all be developed, created, and of course that requires resource and so forth. But the most important thing is there information? Can it be exchanged? And can we make use of it? And I think fundamentally, that's where sort of interoperability stems from. Everything else around it is the culture of making that happen.
Absolutely, Sam. Absolutely. That is what I mean. Absolutely. Around that data, I mean, to what that means to our people. And that's interpretations, the use of it, and the quality of data. Absolutely. Thank you.
Sure, and also recognizing that that data is only one part of the toolkit available to a care provider at any one point in time. They're also having a conversation with the patient that's in front of them. Potentially, there are other sources of things that will inform their decision making at that point. Sorry.
No, that's fine. I know we can talk about this all day.
We could, yeah.
Thank you all for your contributions. Just going back to the questions, the first point which people are agreeing with is the idea of the citizen or people. So someone did make a comment to say, if the citizen is not the point of integration, there will never be an integrated health and care record. The spectrum of data needed to deliver similar services needs far richer data than one organization can hold. So that's a comment, and a lot of people have voted for it, so they agree with it. A question for the panel then is, what are your thoughts on the role of care homes and CQC registered care providers generally in the interoperability agenda? What do you think the strengths and challenges are in this sector when it comes to this subject? I think a very interesting question, talking about social care and joined up care and interoperability.
I agree. That's a very good question. And it perhaps echoes the previous point that much of the conversations so far have been about care providers. We're not good enough yet in bringing patients, citizens into that conversation and enabling their needs to be uppermost. And the care home setting is perhaps the most sharp area of that, where the needs of the residents of a care home are more often than not very complicated and require the input of multiple teams, and the residents of the care home alongside the people caring for them need to be perhaps the loudest voice in that conversation. So what works for them, rather than here's my supplier solution and make of it what you will.
Lorraine, I think there's a bigger issue here, which is we've often ended up focusing on individual parts of the NHS in localities. We focus around geographies. We're in a world where even if we take the CQC as an example, and that's very England-centric, we've got to remember, of course, there's people and patients that span the whole of the UK and beyond. And if the dimension of the CQC might be regulated healthcare providers and care providers, let's take that out of the equation. There are people, citizens, that access health and care services all over the UK, mainly a lot of them in England, but they might be anywhere. And we've got to build a way in which we can work that allows us to think about that citizen accessing different services in different places. So we've got to try and get policymakers to stop thinking just about the services that exist in the confines of what they might commission from one part of the NHS, either geography or nationally, and think about the citizen accessing services that might be non-geographic providers. They might access a digital provider that is completely online and national. They may happen to access an ambulance service in one part of the country that's different to another part of the country. And we've got to think away from what it is that might be in geography, but what is safe and effective care, and how does the system facilitate that? And how do policymakers create standards that allow that exchange irrespective of the boundaries of areas or providers?
Yeah, and so if I could just come very briefly from a national kind of organisation perspective, so there is a specific stream of work looking at social care, and how do we make sure that they are, one, accessing information that is relevant to the care they're providing in a care home, but also how are they able to contribute back in some way to the record, so we actually understand what's been happening in a care home. Obviously, it differs enormously in kind of the care sector. You've got some big care homes, so kind of big national providers that run care homes that have 100 beds and they have a system in place, down to a husband and wife who run a 4-bed care home and don't have a system in place. So actually, how are we catering for that broad spectrum as we go forward in that? And there's a different set of interop challenges in there to some extent. So, for example, I heard a while ago now around a care home that did have a system in place, but they couldn't access any of the national health information until once a week the nurse from the local GP surgery came and put her smart card in so that they could suddenly find out information about their patients. Major issue, which has actually taking steps to being resolved now. So the summary care record application, which kind of is a national view of some of the GP data and other data that we hold nationally, has lowered the access requirement to enable a different type of authentication, which will enable social care organisations. And there's a few pilots running in that space now. So there are different steps, I think, that are happening in different areas. The programme of work around social care coming into kind of merging into the health interoperability space is brand new and is just starting now, but it's already looking towards a platform and what would users need in those different types of scenarios.
I mean, Ian, that's really interesting, and it's obviously useful, and I think it's a good thing that we think about the care home sector, the care sector, but we haven't even got it right in the NHS. NHS providers, optometry, dentistry, they're providing NHS services. Those people access those services, and the clinicians there have no way of knowing what medication they're on or what's taking place. So I do agree that care homes are a great focus, but at the same time, I think policymakers do need to go beyond those and also think about the NHS services as well.
So I agree with you. I agree with you on that. What I would say though is there are a number of national solutions that provide access to that kind of data. So Summary Care Record application is available now. You can view medications, you can view allergies. GP Connect is available now. You can view HTML and a structured version of the record. So the challenge there, I think, is that nationally we need to support local organisations in driving uptake of some of the existing solutions that they might not even know exist right now, but actually how do we push those out as solutions that are easy to onboard to and easy to access.
Julia, would you like to come in?
Yeah, I think it's an observation with respect to care homes and other similar services. I think we have a long way to go in terms of understanding what patients and also their family and friends would like when using those types of services, because I don't think it's always about information relating to shared care records. I think it's mainly or very key is administrative services, because what tends to happen with a complex patient is either themselves or their friends and family become the administrator. You've got hundreds of appointments across different services. You've got people coming at you left, right and centre from the NHS and from social care. And easy technical interoperability to give you even a really simple diary so that you can log what's happening when and who it's with and possibly information about what's going to happen there. That's really, really key and really, really important. So I don't think we ought to restrict ourselves to the kind of the shared care record sort of data set conversations that we typically have around medications, encounters, etc. I think we ought to be innovative about really understanding what people need and making simple things like administration, which in another sector would be quite straightforward, simple for people. That would make a patient experience and a family's experience much richer, because they could then focus on what's really important, which is the more emotional side of helping their family member.
Thank you very much, all. Another question coming in, I guess tying into what you're saying, Julia, but focusing around the patient, is the question was around patients having access to their information, but also thinking about how we maintain interoperability and still give patients or people, citizens, access to their data. What are your thoughts on it?
Well, I think they should have access to the data. I think there are ways to collaborate. I think there's a lot more collaboration needed, and that needs to include all people, including patients themselves, around access to shared to their own information. And I also think they need an ability to contribute to shared care records as well as they can. I mean, I know there are some examples. We had some examples of that within Leeds Care Record and the Yorkshire and Humber Care Record, but that needs to get a lot more mature. I do appreciate, of course, that some information is better in a supported environment, but I do think also that we need to treat people as intelligent people and allow a level of access much more than we do right now.
Thank you very much. I'll just go to one more question before we need to move on. And the question is on funding. The question is there specific funding for systems to implement digital plans, or are they expected to do this within existing budgets? I know, Sam, you talked about resources and funding. So I guess that's the question, if you'd like to start off.
Yeah, I think this is a notoriously difficult thing. So if I go back to having been in probably Ian's space, there are lots of national priorities and programs, but somehow the money has to flow downstream to providers for them to be able to work with suppliers, whether that's a national agreement or something local. So unless there's sufficient resourcing and realistic resourcing in the system, and not just the funding to pay the suppliers, all the other teams in between, the program teams, the project teams, the people that are going to facilitate it, the business change teams as well, to help people work in a different way. We often overlook that. You know, the degree of business change can't be underestimated. Something as simple as just surfacing GP appointment information between a GP system and an app in itself requires business change. So I really would stress the fact that unless it is properly funded from those people that want to make it happen for the system, the reality is it will just become a process change and we won't achieve the outcome of the business and people change.
I think I would add also it needs to be the correct type of funding. There's a lot of funding floating about, but it's not always the right type of funding to enable change.
Thank you very much. I know, Matt, you wanted to come in to Julia's previous point. Would you like to come in now, please?
Yeah, thank you. I was just distracted by the current conversation about the funding is always important, but also the expertise. You know, the right people who have the passion, but also the knowledge to bring about change are important. You know, in my clinical work as a GP, we have funding. We can't recruit people into these areas to both managerial roles, training roles, and clinical roles. Yeah, people and money are important.
If I may add on to that, actually, if the funding is coming in the right time for us to be able to deliver what we say we will deliver. And I think this is the biggest challenge for all of us. And also the timeline, the funding that we get from national teams and everything. So there is a change need to be happening for us to plan ahead so that we can deliver this and with the people with the skill set that you mentioned.
The point that I was going to make to Julia's comment is about the patient being the one who calls the sharing of information and the use of information. A while ago, we were doing an engagement event, and somebody pointed out to me that my organisation's failure to share information with other caregivers was doing her more harm than any concerns over information governance. And I don't think organisations like my clinical organisation set out to be obstructive, but they are very worried about doing something wrong by inadvertently sharing information with the wrong people. So what we need to do is improve people's knowledge about information sharing and also give them the courage to do it when it's in the patient's interest and it's what the patient wants.
Yeah, absolutely.
Thank you very much all. It's been quite a rich discussion, and I know we have lots more to say. There's so much we could have covered by just looking at the time. So finally, we have reached the end of our Q&A, but I'd like to give the panelists an opportunity, just 1 minute of last reflections. Any thoughts, any reflections on what we've been discussing? Just 1 minute each. I guess, Julia, would you like to start?
Well, I think my observation was to recognise that it's complex and it's fast moving, and to be a little bit kind to each other around that, but also to recognise, as we've said, that people and collaboration can do amazing things, and the technology, when you put it together with the people and the process, can really change people's lives, and I'm not underestimating when I say that.
Okay, Savi, your reflections, please.
For me is, yes, the change that we wanted to make sure that we can deliver that, and people in the middle
Oh, go on. Yes, we can hear you.
Sorry, I'm having technical issues and
That's
there is a
fine.
sun rising. My reflection is technology is not what we want to, it's an enabler. We take that as a driver, but we need to take our people together with us. And whatever we're going to deliver, we need to win their hearts and minds, which means we have a fighting chance to make sure that there is outcome benefits that we would have. Thank you.
Okay, thank you. Matt?
A minute, wow. I encourage everybody to read the King's Fund paper. It really is a very good description of the current situation and what's happening, particularly highlighting the work that Julia, Savi and their colleagues have done. Interoperability is a slow-moving glacier. We've been talking about it for 15, 20 years in my area, but thankfully the glacier is always moving forwards. If we can make it move a bit quicker, then everybody's going to benefit.
Okay, thank you. Ian?
But yeah, so I'd encourage everyone, as Matt said, to kind of read through the report. There's a lot more questions that we haven't got to, the 71 questions in total on the sheet, and we definitely have not had a chance to go through all those, but there are definitely some thought-provoking ones in there that I think it would be good to maybe pick up separately. And certainly I know Tom Russell in our team has commented around how you can get involved with some of the national work, but we'll definitely take these questions back and consider them as we develop our strategy as well.
Thank you, great. And lastly, Sam?
Interoperability is, of course, important, but think beyond the process. Think about the problem or outcome you want to solve, and think beyond the borders of individual organizations or areas.
Perfect, that was great. Thank you all for great discussions. You really thought-provoking, ideas and critique, and really enjoyed it. So I guess this is, thank you speakers, and those that are watching, we've come to the end of the session. We encourage you to share a link to the event with colleagues who can register and watch it on demand. It's going to be up for a few weeks. Please navigate to the feedback option in the menu on the left, and we will send out a survey link in an email shortly. And we really value feedback to help us continually improve our events. So please do give us any feedback. And again, as has been mentioned, our report is out. I would really encourage you to read it. There's so much to think about and so much in terms of discussions and also recommendations in there. And we also do welcome your feedback on the report as well. So finally, thank you again to TPP who have sponsored and funded our event, and everybody have a good afternoon.